Welcome to today's Explainer. We are jumping right into something notoriously tricky in medical imaging, sternum radiography. If you're a focused learner trying to master the art and science behind the perfect image, you're in the exact right place. We're going to break down the highly specific positioning and protocols required to get a flawless picture of the breastbone. By the end of this session, you'll have the exact geometry and techniques you need to nail this every single time.
Okay, let's dive right into this. How do you image a bone that is literally hiding right behind the spine? That's our core anatomical challenge here. Superimposition. The sternum sits right in the middle of the anterior chest, directly in front of that massive, dense thoracic spine. If you just shoot a straight-on X-ray, the spine totally washes out the thinner sternum. So, how do we fix it? We have to get creative with our angles.
Here's a quick look at our roadmap for today. 1. The Sternum Imaging Challenge. 2. Mastering the RAO position. 3. Perfecting the lateral sternum. 4. Adapting for trauma patients. And 5. Evaluating your radiographs.
Section 1. The Sternum Imaging Challenge.
You know, as a technologist, you aren't just pushing buttons. You're a real-time problem solver using physics to get around the body's natural roadblocks. To see the sternum clearly, we use the PA oblique projection in the RL position. Basically, we physically rotate the patient just enough to visually project the sternum off the spine and over to the left side of the vertebrae. And here's the brilliant part. We're projecting it directly over the heart. That homogeneous heart tissue acts like a perfect, smooth backdrop that actually boosts the radiographic detail of the sternum.
Moving on to Section 2, Mastering the RAO position.
Now, getting this right isn't just about how you turn the patient. Your equipment settings are absolutely crucial. 30 inches. Burn that number into your brain. For the RAO sternum, we drop our source-to-image distance way down to exactly 30 inches. We pair that with a nice tight 10 by 12 vertical collimation. Now, sure, if you're stuck using a standard 40-inch SID, you'd collimate down to 8 by 10, but 30 inches, that is your gold standard protocol.
So why so close? Usually, in radiography, we want a longer distance for a sharper image, but here we're totally flipping the script. Bringing it into a 30-inch SID intentionally creates geometric unsharpness for the structures furthest from the receptor. It literally blurs out those posterior ribs that are in the way, which actually magnifies and increases the detail of the sternum itself. It's basically a highly specific hack to melt away visual distractions.
All right, so how do we physically get them set up? Upright or prone? Well, upright is almost always better for patient comfort and breathing control. You'll align the patient so the long axis of the sternum is dead center to the grid midline. Then make sure the top of your IR is about 1.5 inches above the jugular notch. That guarantees you capture the entire bone without clipping the top.
Now, what's really interesting about this slide is the nuance of rotation. It is for sure not a one-size-fits-all angle. To figure it out, just place one hand on their sternum and the other on their spine. Do they have a deep barrel chest? If so, you only need about 15 degrees of rotation because the sternum is already pushed further out from the spine. But if they have a shallow chest, you'll need to crank it up to about 20 degrees to successfully clear those vertebrae.
Once you have your rotation locked in, let's align this central ray. Keep your CR perpendicular to the IR. You want to enter the elevated side of the posterior thorax. To find your exact spot, go midway between the jugular notch and the xiphoid process, and about 1 inch lateral to the mid-sagittal plane. That pinpoints the sternum perfectly.
Section 3. Perfecting the lateral sternum.
Okay, so we've cleared the spine from the front. Now let's look at it from the side. Ready for some whiplash? 72 inches. Look at that massive contrast. We just spent all this time talking about a super short 30-inch distance, but for the lateral view, we are pushing the tube all the way back to a 72-inch SID, paired with an 8 by 12 collimation.
The logic here is exactly the opposite of what we just did for the RAO. Since the patient is standing sideways, the sternum is now super far away from the image receptor, which creates a huge object-to-image distance. If we shot that up close, the magnification would be totally out of control. By bumping our distance out to 72 inches, we fix that magnification and bring back our sharp detail.
Let's walk through that lateral setup. Have them stand or sit upright, side directly against the board. Center the sternum light 1.5 inches above the jugular, just like before. But here is the real trick. You need the patient to forcefully roll their shoulders back and lock their hands behind them. You absolutely have to get that thick shoulder tissue pulled out of the way of the upper sternum. And of course, double-check that they are perfectly perpendicular to the IR.
Your CR is perpendicular again, entering the lateral border midway down the sternum. But let's talk about breathing, because it's a total game changer for this view. Instruct the patient to take a massive breath in and hold it. Suspending respiration on deep inspiration fills the lungs with air, which gives us this beautiful, sharp radiolucent contrast right behind the solid posterior sternum.
Section 4. Adapting for trauma patients. Let's move to and see how this builds in the real world. Everything we've discussed assumes your patient can stand up and take deep breaths. In trauma, that's rarely happening. If they're flat on a backboard, you just adapt. The RAO simply maps over to an AP oblique in the LPO position. You're achieving the exact same anatomical clearance just from the front. And that upright lateral? It just becomes a cross-table lateral.
Now, when you're shooting that cross-table lateral, if the patient is physically able, you absolutely must get their arms up above their head. If their arms are resting down by their sides, your beam has to plow straight through the thick humerus bones, which totally washes out the sternum. Getting those arms up decreases the OID and seriously rescues the detail in your image.
Finally, Section 5. Evaluating your radiographs.
All right, before you ever hit send, you have to grade your own work. Here is your RAO checklist. First, do you have the entire sternum, jugular to xiphoid? Is it projected smoothly over the heart and totally free of the spine? Remember, we want minimal rotation, just barely clearing those vertebrae. If you see a massive gap, you over-rotated and distorted the bone. Make sure the lateral manubrium is clear, and if you used a breathing technique, look for those nicely blurred pulmonary markings in the background.
So, the crucial point is applying that same critical eye to your lateral view. Whole sternum visible? Check. Manubrium totally clear of the shoulders? If not, their arms weren't pulled back far enough. Is the sternum completely free of rib superimposition? That tells you it's a true lateral. And finally, ensure the lower portion isn't obscured by breast tissue, which might require some careful, respectful physical adjustments before you expose.
I really want to emphasize this thought. Taking an X-ray of a hand is pretty straightforward, but capturing the sternum? That takes genuine technical skill. Nailing these subtle angles, knowing exactly when to drop to 30 inches or pull back to 72, reading the depth of a patient's chest, that's the stuff that takes you from being a decent technologist to an absolutely exceptional one.
You've got the blueprint now. You know the exact how and why behind the RAO and lateral protocols, right down to the collimation and trauma workarounds. So my question to you is, will your next sternum radiograph perfectly clear the spine? Take these rules into the clinic, trust your angles, and keep refining your craft. Thanks so much for joining me for this explainer, and happy imaging!